Good day, and welcome to Epstein Becker Green's webinar, Telehealth Crash Course, How Do I Implement Telehealth in My Plan? Please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You are welcome to submit questions directly to the presenter following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. Before we begin today's presentation, I would like to remind everyone of the upcoming final installment in this series. Please join us on September 29th at 2 p.m. Eastern. You can register for future webinars by visiting www.ebglaw.com/events. We are pleased to feature a fantastic speaker today. Adam Solander is a member of the firm in the Healthcare and Life Sciences practice of Epstein Becker Green in Washington, D.C. At this time, I'd like to turn the webinar over to Adam.
Thank you so much. And for today, we're going to switch gears a little bit from what we've been doing in the Telehealth Crash Course series so far and focus really on how employers are implementing telehealth into their plans. So I'm going to talk a little bit about the employer market and why employers are looking to telehealth in such great numbers at this point. Then I want to talk a little bit about your options for incorporating telehealth into both a group health plan and into your workforce more broadly. After that, I also want to tackle some of the privacy and security concerns that we get asked sort of on a daily basis. So without wasting any more time, I'm going to move on to the next slide. So the real impetus for this explosion in telehealth in the group health plan market, I believe, is due to the Cadillac Tax, which takes effect in 2018. So basically what happens in 2018 is that the cost of employer-sponsored care will be subject to a tax. The way this works is if the cost of your care exceeds certain enumerated thresholds, those are $10,200 for individual coverage and $27,500 for family coverage, you're subject to a 40% excise tax on the amount that your coverage exceeds those amounts. So, for example, if you're offering individual coverage and the cost of that coverage is $11,000, you will be subject to a tax of 40% of $800. So it gets up there pretty quickly. The real problem with this is that those thresholds are indexed to something called CPIU, which is a Consumer Price Index Urban. The problem with that indexing, while indexing it to inflation is good, is that employers, through their group health plans, are really paying for medical care. So the appropriate gauge in which to measure inflation would be medical inflation and not CPIU. So basically the way this works out is that CPIU has been almost flat for the last 5 years, while medical inflation has gone up 5 and 6% every year. So doing absolutely nothing, employers are going to creep up close to those thresholds every single year. So what employers are doing is they're looking for innovation. They're looking at ways, both through population health and the way in which they're paying for care, to lower the cost of their coverage. They want to make their populations healthier, and they want to pay for care in an innovative way to reduce those costs. The good news about telehealth is it really checks both of those buckets. So it's something that employers are really looking at optimistically as a way to save themselves under the Cadillac Tax. There's a couple of different ways that employers are implementing this. It's certainly not without risk in certain contexts, but we're seeing it in 2 ways. There's the sick care. There's the general telehealth that's out there, which is what we're probably most familiar with on this call. This is the platforms where you use technology to reach out to a physician who will diagnose a common illness and prescribe. The other one is that employers are using this now, and we're seeing a lot more of this in disease-specific ways. So specific providers who target cost drivers in a plan, so diabetes, heart issues, hypertensiveness, that kind of stuff is all covered now under telehealth in sort of a standalone telehealth offering. Moving on to the next slide. There's a couple of different ways that we're seeing both types of programs being implemented. By far the most common way that we're seeing is that telehealth providers are being included in the group health plan. To a lesser extent, we're seeing telehealth providers being offered to the workforce more generally through either an EAP, a wellness program, or an on-site clinic. There are certainly advantages and disadvantages. I think when you look at this from a risk perspective, certainly implementing this as an EAP or a wellness program would be a lot riskier than doing this as a benefit under your plan. So the way this works is if you're going to include it as a benefit under your plan, basically the telehealth platform is included the same way as any other provider would be. So your enrollees would, go to the providers, TPA would administer this, and the applicable cost sharing under the plan, et cetera, however you have it set up, would apply. This would all be run through a TPA, and it would all be offered under your health insurance plan. There has been some hiccups in this. Telehealth is relatively new. This requires a lot of coordination with TPAs. The TPA is going to be responsible for administering this benefit. So it's important that whatever telehealth platform that you're considering implementing, you're checking with your TPA and making sure it's something that they can implement without too great an issue. Telehealth is something that is new for both employers and TPAs. So there's been a lot of confusion on how to implement this into the health plans. As simple as what contracts do we use? Is the telehealth provider really a software as a service, or is this a provider? These are the sort of problems that we're working through. I think these things are starting to go away as everybody realizes the benefits of telehealth and how to incorporate it in group health plans. But there's certainly a level of coordination that needs to occur with the TPA in order to use telehealth in the group health plan context. In this context, telehealth would only be available to enrollees in the group health plan. So if you're incorporating telehealth in this manner, you couldn't offer it to all your employees. It would just be people who have signed up for the group health plan. And there's also a compliance concern here. One thing that we see missed a lot is that telehealth is outside of sort of the normal plan offerings at this point. So if you're an employer, you're offering this, you're a plan sponsor, you want to make sure that you're in compliance with the various laws. A couple of things that come up frequently is mental health parity. So making sure that your benefits are offered in parity with the mental health benefits under your plan. Another issue that we see all the time is high deductible health plans. You're not allowed to apply any kind of discount until the out-of-pocket cost sharing is met under the plan. With a lot of telehealth providers, they're more innovative than I would say a lot of other providers out there. So they're looking to drive utilization of their platform and may be implementing discounts and that type of thing. So that's something to watch out for if you have a high deductible health plan, and not allowing discounts under the group health plan until that out-of-pocket spending has been met. The other way that we're seeing this is through wellness programs and EAPs, and this is certainly the highest risk way to implement telehealth for employers. But as in this context, their employers are really seeing that the value of telehealth would reach way beyond just their employees that are enrolled in the group health plan. It's something that in most cases is cost effective. It can help the employer with presenteeism, absenteeism, productivity. A healthy worker is certainly a productive worker, and a worker that's at work more than somebody who's not feeling well, who may not have access to care. So we're seeing a lot of employers trying to get this to the workforce more broadly. The problem with this is that under ERISA, any benefit that offers medical care would be subject to the Affordable Care Act unless it constitutes an accepted benefit, which is a term of art under HIPAA. Basically, if the benefit that you're offering provides medical care, it would have to meet all of the ACA market reform provisions. So it would have to provide minimum value. It would have to have all of the essential health benefits if it's a assured product. You couldn't have annual and lifetime limits. There's really no way that this can be done with most of the telehealth platforms out there today. So what would end up happening is if this is something that provides medical care and is a group health plan under ERISA, the employer could be subject to the entire employer mandate penalty, which is $2,000 times the number of full-time employees you have minus the first 30 employees. Additionally, if this is a group health plan and offered to an employee, it could stop that employee from getting a subsidy to purchase coverage on the exchanges because those subsidies are not eligible for people who have employer-based coverage. So with all of that said, there's certainly an out here. If you can structure telehealth as an accepted benefit, then you can provide it to employees without being subject to the ACA. There are sort of 4 qualifications for this. First, the program cannot provide significant benefits in the nature of medical care. There were some regulations released, I believe, last year where they attempted to define this as a certain number of outpatient procedures, an HR wellness checkup, that kind of thing. That would be the main sticking point for classifying telehealth as an accepted benefit for most plans. If you're offering sort of a full range telehealth service offering, it'll be difficult to scale down the product that you're offering to make sure that you're not providing quote-unquote significant benefits in the nature of medical care. They also can't be coordinated, so you can't use the EAP or the telehealth offering in this case as a gatekeeper to your benefit plan. Like, you have to satisfy the telehealth before you can go use other physicians under the program. There also can't be cost sharing, and there can't be employee premiums. So with that said, I think that it's pretty clear that you could offer those standalone telehealth services the same way that you could offer standalone vision and dental under your plan. I think that's pretty clear. I think that conceptually, there's also the possibility that you could structure a telehealth program that would meet the accepted health benefits. Any EAP that provides only referrals, there's guidance out there to that effect, would not constitute a group health plan or would not be subject to the ACA. And so it is conceivable that you could develop a program that would constitute accepted benefits and could be offered to the workforce as a whole. Certainly, programs where, the employer has a health fair, includes telehealth benefit offerings, that sort of stuff will be okay. One other sticking point is that even if you qualify as an accepted benefit EAP program, telehealth EAP program, you still may be a plan under ERISA, even though you're not subject to the ACA. So there still may be filing requirements. You might have to file your 5500, your SPD, the claims procedure rule, all that sort of typical plan stuff. So that is really the two ways in which employers are implementing this into their populations. But now I want to move to another topic that we get all the time in the employer context. If telehealth is provided through the group health plan and it's a benefit under your plan, the chances is that the telehealth provider is a covered entity under HIPAA. We always see sort of these fights going back and forth about the data. If the telehealth provider is a covered entity under HIPAA, as an employer or as a group health plan, you're not going to have the ability to control that data. It's the same as if your enrollees went to the hospital and got a service there. And really, as a group health plan, you don't want that information. Most of you are operating under the exceptions for group health plans that receive only aggregate data, so it's not data that you would want anyway. We see a lot of contracts coming out, and largely because of the confusion with telehealth being new, where employers are looking to get that employment or that healthcare data back from the telehealth providers or get some sort of reporting, that kind of stuff. That is something that can certainly increase the risk to your plan. It can also increase your employment liability as well, as if you are getting that information, it's easier for a disgruntled employee to say that an employment decision was made on the basis of healthcare information. So it's important to remember that the telehealth provider really is a provider and not a wellness program or somebody who may be providing services that don't really reach that level. The other main point here is that if you're providing telehealth as an employer and not as a group health plan, depending on the scope of services, it's likely that you're not even subject to HIPAA. So there aren't those data sharing requirements out there, and as an employer, you want to really make sure that you're comfortable with the sharing of that data. As an employer, you're still subject to state privacy and security laws. You're still subject to FTC, various other laws out there that protect data. So you still, even though a provider in that context, because they're probably not doing a standard transaction because they're not billing that way, you still want to make sure that you're comfortable with the way in which they're handling your data and still have those agreements outstanding to make sure that you're protecting that information to the extent possible. That is all we have for this series today. My contact information is on the next slide. Please feel free to reach out to me if you have any questions about anything that was covered today. Thank you.
Thank you for joining us. This concludes today's webinar, and approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. If you have any questions, please feel free to contact today's speaker, Adam Solander, at asolander@ebglaw.com or via phone. Please join us for the upcoming final installment in this series on September 29th at 2 p.m. Eastern. You can register for future webinars by visiting www.ebglaw.com/events. Thank you.